Welcome back to the Health Longevity Secret Show with Dr. Robert Lufkin. Can a ketogenic diet reverse chronic disease? Today, we find out from Dr. Vyvyane Loh, founder of the Transform Alliance for Health and board certified in obesity medicine and internal medicine. She graduated from Boston University School of Medicine and trained at the Newton-Wellesley Hospital. Unlike most physicians on our program, or indeed anywhere, she is an accomplished choreographer and fiction author who won the Bunting Radcliffe Fellowship in Fiction in 2006, a Guggenheim Fellow in Fiction in 2008, and was shortlisted for the 2005 International IMPAC Award in Literature. Now, please enjoy this interview with Dr. Vyvyane Loh. Dr. Vyvyane Loh, welcome to the show.
Hi, Rob. Good to see you.
Hey, thanks so much for being here. Before we get into metabolic health and obesity and all these interesting things, I want to take a moment and just take a look at your history. As we said in the introduction, unlike most physicians on this program, or indeed most physicians anywhere, you are an accomplished choreographer and fiction author who won the Bunting Radcliffe Fellowship in Fiction in 2006, a Guggenheim Fellow in Fiction in 2008, and were shortlisted in 2005 for the International IMPAC Award in Literature. That's a fascinating and very unusual background. How did you come to explore such diverse endeavors at such high levels of accomplishment?
Oh, well, I've always been interested in writing, dance most of my life. So these were just parts of what I did since I was a child. And I actually got my MFA in fiction right after I finished my residency. Very shortly after I finished my residency and I started my first job. And I actually went into burnout quite shortly after that. And I always say it was a gift because I burned out early. I burned out maybe 2 years after residency. And I had to face the fact that, okay, I've just gotten through med school, I've gotten through residency, I'm working as a doctor. I'm not going to last.
That was physician burnout, to be clear, right? Yes. So it was, you did an intensive residency in internal medicine and then a fellowship in obesity medicine also?
I did. So with obesity medicine, there's no fellowship, but I'll get into how I got into obesity medicine. Yeah, I realized very shortly after finishing residency that, okay, you've done all these things, but you've got to last or you're not going to have a career. How am I going to survive the X number of years that are ahead of me? And I was already burnt out 2 years out from residency. And that was a huge smack in the face. And at that time, there were practically no resources for burnout. And you remember the whole, grit your teeth and bear with it and the stiff upper lip and, So that was the climate that I had been working in. And I just had to look at myself and go, you know what, this is going to be a problem. You're not going to make it just at this rate. So I really had to take a big step back. A huge step back. At the time, right before that, I had applied for my MFA in fiction, and I won a scholarship, a full scholarship to do that. So this was all around the same time, and I found out that I had gotten the scholarship. I was going to start the MFA, but then there was still work. When I realized that I couldn't, continue practicing the way I had been practicing, I took a huge step back and I actually quit my job. I quit my full-time job, which was very scary. It was extremely scary for a number of reasons. And I'll just be very open here because there's nothing to hide. I was here on a work visa, And my employer at the time was applying for a green card for me. So quitting the job wasn't just quitting the job and quitting a salary. I basically became out of status, right?
Wow.
Yeah.
Wow.
So I was an illegal alien. And for someone who's, I went to medical school, I always did well in school, I always followed the rules. This was terrifying. You can imagine I wasn't sure what to do. And then I had to figure out also how to patch together a living, because now I didn't have a salary, right? So I had the school, the scholarship, but I still needed to live. And so I remember at the time I had been working out at a gym, and for some reason I had taken a certification in a spinning course. And I was at the front desk and I overheard them talking, and they were saying, that spinning instructor isn't going to be able to do, the next few weeks and blah, blah, blah. And I said, I can do that. So they said, oh, okay, can you audition? And I made up a tape, with music and everything, and auditioned. And they said, sure, you can teach the class. I taught the class. And then they said, hey, can you teach aerobics? Never done aerobics in my life. Oh, yeah. I went to the library, borrowed all those old Jane Fonda tapes, memorized the routine, right? And then it's harder than you think, because you have to do it mirroring the person on the other side. You got to speak you got to be pretty fit. And I was like, oh my God, I'm going to die. I did this. I had a background in that. So, I was able to kind of cobble it together. So next thing I knew, I was teaching all of these classes. I made up some classes. I did get certified as a personal trainer. So I did all these things, right? And at the same time, I was going to school. Now, the program I was in was a long distance program. So it meant that I went on campus twice a year for 10 days. But the rest of the time, I worked intensively with a professional writer. And I think it was 3 weeks, we had to send in what we called our packets back in the day. And it was a substantial chunk of writing and reading and essays and stuff like that. And then we would get very, very good detailed feedback. I was in the Warren Wilson program, which is quite well known. Anyway, so I was doing that. And then I still needed a little bit more, income just to survive. You can't just, teach aerobics all day. You wear out your body. So I also started to moonlight, and I bumped into a surgeon who was at the time the chief of bariatric surgery at the residency program that I had been in. And he said, hey, what are you doing these days? Nothing. He said, hey, I don't think he took me seriously, but he said, you know what? He's a surgeon. He says, I like to do surgery. I don't like to actually see patients. So why don't you, I do this obesity clinic I have to do. Why don't you cover for me? I said, really? Okay. I didn't know anything about obesity. And I went in and covered and did the best I could. And he came back and he said, yeah, you know what? The staff like you, the patients like you. Why don't you take all my clinics? Okay. So that's really how I got started. But I got hooked very quickly because it was the first time in my career that, I would go in and take people off medications, right? I would go in and see people's blood pressures improve, that they were getting better over a period of time. And it wasn't adding another layer of medications or whatever, right? Or a medication for the side effects of that one, for the side effects of that one, and, chasing that. So I got hooked pretty quickly because it felt great to actually feel like you were helping people and that they were on a track towards real health, right? So I did that. I also did some hospitalist moonlighting, and I, at the time, took on some jobs in dance and choreography and teaching. So I basically did everything, taught anything. Can you teach English? Mm-hmm. Can you teach Portuguese? Mm-hmm. Can you, it was anything because I needed the money. So, I spent that time, cobbling together a living, but at the same time, as I said, I had to figure out now, how am I going to last the course? So this is when I realized, okay, this is ridiculous. I have been in training in med school, in residency, and I didn't know how to take care of myself. absolutely ridiculous when you think about it. You're a doctor and you don't know how to take care of yourself. How stupid does that sound? I was saying that to myself, and I thought, yeah, that's bad, because here we are pontificating to our patients, and you should do that. And I can't do it myself, right? Who am I to lecture them? I can't even help them because I don't know what it means to be healthy, right?
Yeah.
And that's when I decided to take a deep dive into what it means to be healthy. So reading, exploring, learning as much as I could from that point on.
And that was the beginning of sort of your continuing interest in metabolic health and chronic disease and all. So metabolic disease is arguably the greatest epidemic we face in the world today, COVID-19 notwithstanding. What did you learn about metabolic disease in your studies there that you didn't learn in medical school or residency, or what clicked with you there?
I think it's understanding, our physiology and how the body tries to compensate when we're living lifestyles that go against our physiology. So for example, I'll take sleep, because, as physicians, we know that we are chronically sleep deprived, and we do that in training, and we think we sometimes pride ourselves on how little sleep we can get by on. And so actually it's one of the dumbest things to do, but so you have the brightest people in the world going to med school, going to residency, doing the stupidest thing possible for their bodies, right? And you're like, wow, great system that we have, right? So learning about how we actually work against ourselves in terms of our lifestyle, sleep, nutrition, obviously, lack of activity, the types of activity we choose, and then just the kind of pace that we put ourselves through on a daily basis. So all these things, they look very general, but if you take a deep dive, you can spend time in any one sector and really just kind of, go crazy with all the information that is out there. What I've always said is, unfortunately, we've got plenty of great research, lab, bench work, that kind of stuff, but a lot of that isn't taken into the clinical aspects of our career. So we don't know how to apply that information. You see what I'm saying? So there's a big gap between, the knowledge base and what we have clinically. So if you imagine, if you had a kid who wants to go to school to learn to be a programmer, and you're going to pay some expensive college fee, and this kid's going to go off and learn to be a programmer. It's worth it because he'll have a great career. And on first day of school, they give him some index cards and they give him a little puncher, and they say, look, you just punch these holes, right? Which is how we used to code. We would just punch these cards, and then the computer would be several rooms wide because you had to store all these cards, right? So as soon as you found out that this is what he or she is learning, you'd say, okay, out of there. I'm not paying, an ungodly amount of money for you to have obsolete information, correct? Now, what we're studying in medical school today, they were studying 40 years ago, whatever, I don't know. We're obsolete in the curriculum, really. And but the research, the science has moved far ahead. The clinical aspects, the clinical applications are still like, that's where my focus is right now. So I think that's a big disservice to everyone.
Yeah, when I went to medical school, I remember, and my early years of practice, I remember studying diseases like dementia or groups of diseases, dementia and stroke and heart attack and obesity and diabetes and some forms of cancer as essentially isolated diseases that people got. And maybe stroke was related to cardiovascular disease, of course, but it's fascinating now that we're seeing all of these diseases linked at a basic level through metabolic pathways and the same things that that predisposes someone to dementia may also predispose them to heart disease, to even some forms of cancer. I wonder, again, in the early days of my career, or up until about the 80s, the number one cause of, I think, fatty liver disease was alcoholism and all. And then suddenly that's now changed, and metabolic disease is just exploding with epidemics of obesity, diabetes, et cetera. Why is that happening? What causes it? What caused that? What are we doing differently now that we didn't do 10 years ago, 20 years ago? Is it all about sleep, or what other factors are there that we're doing?
So, I mean, I think the first thing to point out is that things don't, change on a genomic level vastly within 20, 30-year span of time, right? So this is clearly an epidemic that is secondary to exposure to something, right? And probably multiple factors. I think the key one for me would be poor nutrition, poor nutritional choices. And then also the whole lifestyle, where it's around our ability to, utilize our circadian rhythms the way it was meant to be. We seem to resist that and push against that. So we're, hell-bent on working against our own internal rhythms, right? That, and, we could put in things like pollution, for example, and, inability to regulate our emotions and our arousal in our day-to-day activities. So you call that stress, but it's really this inability to cope with the environment, so that we try to compensate in ways that might not, in the long term, be healthy. In the short term might work for a little while, but long term probably.
So it's really multifactorial, as you say, and like you say, our genome hasn't changed in 50 years. So it's really the environment and choices we make in our lifestyle. It seems like lifestyle has sort of gotten a bad rap, because I remember for years people saying, oh, you just need to improve your lifestyle. Well, what does that mean? Well, it means exercise more and eat less, and it didn't really work for a lot of people, and it's not really actionable. So people say, well, lifestyle, doesn't work. Just give me the statins or give me the hypertension meds or something like that. How are you approaching lifestyle now that's different with actionable items?
So when my patient comes in the first time on what I call my initial consult, I always ask them, okay, so, we reverse your metabolic disease. We get you to a much better place. What's life going to look like for you from that point onwards? Like the rest of your life, how are you going to live? And they always come back with something like, oh, I'm going to have a healthier lifestyle. I'm going to exercise more and eat healthy. This is generally what I get. I said, what does that mean? What does it mean? I mean, do you have any sense? Can we break it down into concrete daily activities? And most times they look at me like, I don't know what she's talking about. So I always tell them, look, I don't expect you to know, but, people always say that they want to have a healthy lifestyle, but what they don't realize is there is a cost to that, right? And most people, when presented with the bill, don't want to pay because they don't have that sense of value for what health means, right? We're usually taught in school, as we're growing up in society, to look at financial cost of something. We're not looking at total cost. Total cost would include your health costs, your emotional health, social cost, mental. So we don't know how to look at that total cost. So we only go with, let's say, a number in the bank account. So when they realize that they have to make different choices, but in order to make those different choices, then you have to walk it back. And it starts with, what's your grocery list going to look like? What's the rhythm for making sure you get those groceries? What's your meal prep rhythm? Is there one? What are you willing to do in a social environment that's different from what you do now, right? So nobody wants to talk about the nitty gritty. Everybody wants to say we'll have a healthy lifestyle. In our heads, we have this image of ourselves in some yoga room, meditating in lotus position. But that's really, just the image. It breaks down to very concrete steps that most people can't even visualize. So, there's the science part, which we do, but then I work with my entire team to help the patients actually get to a point where they are executing those steps, right? And we tell them how they're doing, Rob. They all get report cards from us. And the first time we present them with a report card, so I give them a few weeks because I always tell them I assume 0 skills when you start. So fair enough. I don't care if you're a doctor, if you're, it doesn't matter. I assume 0 skills. But, after, around week 4 or 5, we start, grading you. Then you get your report card. And when they get the report card, all hell breaks loose. My manager, Driss, he knows this. Like, they're getting their report card that week. Lock the door because they're lining up outside. So going, I only got 5 points here and I should have gotten 1 more. And I did get my homework in. And it was 5:06. I know you said 5 o'clock. And they argue for that 1 point. So, but I think they're shocked at how poorly they're doing because in our heads, we think that, we're doing well. When we look at it, actually you've skipped half your meals this week. Right? And people don't realize that. So they think, I think I'm doing well. I'm eating healthy, but that has no meaning if you're not measuring it and presenting patients with the feedback.
Even the concept of eating healthy is challenging to patients, I think, because there are so many different definitions of what healthy is and sort of competing diet camps that are almost political, and the patients, they turn to the food pyramid and they look at that, and this is from my government, so it must be trustworthy advice, or they look at other things. How do you sort through all the conflicting opinions about what's healthy and, drink orange juice, but it's full of sugar and it's like,
Yeah. So the first part, obviously self-education, and we do that on a continual basis, my whole team, and we try to make sure that our knowledge base is as up to date as possible. So actually we spend a huge amount of time on literature review. I consider that part of my job. But then when someone wants to work with me, it's mandatory. We have these classes, and it's mandatory that they attend these classes. We set them up in 12-week blocks, and it's 3 hours a week. 3 hours. You can't do 3 hours and then they tell you, oh yeah, my health is number 1, it's a big priority, I really need to. You can't do 3 hours in 168 hours. It's not a priority. Right?
Right. Yeah.
Because watching Netflix for 3 hours and you don't think about it, right? So, we do try to make sure they get good value, and most patients, I try to be a little entertaining, and, I joke with them, and, they seem to enjoy the classes, but we spend a lot of time with the science education, and then we also spend a lot of time with the behavior work, right? So using cognitive behavior therapies based, techniques, DBT and so forth, just to help patients, because a lot of this is inability to regulate and cope with the environment. And then they use a substance or a behavior to help them cope, right? So if you're not going to give the patients those tools, then you're sending back the patient to a similar environment, because after all, they live in a family unit, they live and work in a group environment, right? Most people. So it would not be very helpful if you're not giving them some tools to also deal with that. But the science bit, I have a curriculum, so I will talk about metabolic disease, I'll talk about insulin resistance, and then I will also talk about, body composition, muscle health, because we really don't evaluate our patients on a weight or even a BMI. Really, I heavily go with the body composition. We're very lucky we have our own DEXA. So all my patients get a body comp by DEXA, and we follow them that way. And we train them to look for the right numbers, right? Because the numbers they're taught to look for is that number on the scale. And that could that's not really very meaningful. I would give them the example where someone came to me with it was just someone we were doing a DEXA on, and he had a BMI of 31. Percent body fat was pretty good for a male, it was 20%. And then he came back 3 months later, his BMI was 33. His percent body fat was 17%. So he dropped the fat, he'd increased his muscle mass. So this one, it actually got better metabolically, but if you looked at that BMI, it's meaningless, right? And then just one point, because I did mention that 20% and 17%, and all these people are probably going, oh, but my trainer says I am 10% body, but you are not. That is a bioimpedance tool. It's very inaccurate, and please, no.
Yeah.
So, the people who tell me you have 4% body fat, you must be dead, right? No, it's just not, right?
So for nutrition, for managing patients with metabolic disease, do you find that one approach works well for everybody, or is it some people are keto, some people are, I don't know, high carb, or is there one general philosophy for your practice?
So if you look at the RDA for carbs, and I don't really go by RDA, but let's just put that out there, right? It's around 120, 130 grams of carbs a day. And the average American manages to supersize it to about 400 grams a day, right? So if we just look there, everybody will benefit from cutting the carbs. Because even if we use the RDA, right, which again, I don't really go by, but if we went by the lowest standard possible, everybody's still failing, right? Mm-hmm. Did you see how I sneak that in, the lowest standard possible? Yeah, okay. So, anyway, so we went by the lowest standard possible. We're still failing. So I do, as a start, get most people off the extraneous carbs, especially in the processed carbs and so forth. So it's a good approach, population-wise here, I would say. And then beyond that, there are other, things to consider, because I do look at that protein intake pretty carefully. And because I'm very interested personally right now, we go into these phases. So right now we're into the sarcopenia phase, right? And sometimes these phases last 6 months, a year for me, and then I just go into a deep dive and things like that. So I've been interested in body comp and sarcopenia for a long time. So, prioritizing the protein, how do you dose it, frequency, that kind of stuff, different age populations, because as you know, as we're older, we have more anabolic resistance. So how do you deal with that, right?
Maybe define sarcopenia for our audience. We've heard that, we've talked about it before, but just remind them.
Yeah, interestingly, sarcopenia, I think a lot of people have been taught to think of it as low muscle mass or lack of muscle mass, right? But there's also a strength function in there. Used to be called dynapenia, but now the European Working Group on Sarcopenia in elderly people. Why would you have an acronym like that? Whatever. Anyway, then people in Europe decided they were going to combine strength and mass. And just lump that together in terms of that term sarcopenia. In general, I do the easiest way. Of course, you can use those little squeeze things, the dynamometers for strength, grip, and so forth. But one of the easiest ways to quantify a sarcopenia would be to look at the muscle mass, because we do have a DEX. So we will use that. And you want to make sure that you're not losing your muscle mass as you age, which is the normal tendency, 3 to 8% post your, 40s every decade, right? And if you're sedentary, it's even higher. So, and people don't understand that muscle mass is your glucose sink, right? You shrink the reservoir, you shrink your sink, and immediately, your blood sugar control is going to change drastically. So muscle mass is really important, and most diabetics have accelerated muscle loss. When you look at all chronic diseases, you look at people with chronic cardiac illnesses, pulmonary disease, cancer, right? You have these terms of cardiac cachexia, pulmonary cachexia, or cancer cachexia, where cachexia is a profound wasting syndrome, right? And what we're primarily worried about is the wasting of the muscle mass, right? So once you lose that muscle mass, metabolically, you're a very different creature. That's number one. And secondarily, it's indicative that there is a chronic inflammatory process that's happening, right? That is out of control and really hard to kind of take a hold of. Now, the challenge is because we have 42% prevalence of obesity in this country alone, and about over 70% of people are overweight or obese. If we're just going by BMI, if we go by percent body fat, we are closer to 95%. 95% of people in the obese category, if going by percent body fat. Okay, I can just very confidently say that because I see this day in, day out. All these people coming in with the normal weight or the normal BMI, and you look at the percent body fat and they are obese, which something I call normal weight obesity. So now let's just take someone, BMI, let's say 36. Okay, this person goes through chemotherapy, several rounds. BMI is coming down, 32, but you take a look at this person like, God, still looks pretty good. Yeah, you would never suspect that this person might be undergoing cancer cachexia. Why? Because we started with a high BMI. We don't know how to separate fat mass from lean mass. So we look at that person, we go, yeah, you're doing okay, right? But they may have had profound cachexia and lost a lot of muscle mass. That is not good. And we miss it. The best time to treat something like that is when they're pre-cachectic, but by the time they get to like 5% loss in their muscle, very hard to treat, right? And they have the profound wasting, and 20% of all cancer patients die from the wasting, not from the cancer, not from the treatment. So 1/5 of cancer patients will die from the wasting itself.
Wow.
Right? And we know that. And then we see that in cardiac cachexia, pulmonary cases, the COPDers, and they're just kind of shriveling before your eyes, but we're not doing anything to prioritize that muscle.
Wow. Well, for the obesity patients, I mean, the numbers you gave are just incredible. How effective are lifestyle changes for obesity? For example, we hear people talking about using a ketogenic diet to suppress appetite and weight loss that way. Is that something you found effective?
Yes, it is, with some caveats, right? The World Health Organization talks about the double burden of obesity. And by that, they meant that the same people who might have an increased weight, right, in excess calorie, also are malnourished, right? So you see malnutrition in the same person who has overnutrition. We're just looking at different components of the nutrition. So they may have more excess energy intake, but they're not taking in good quality nutrition. So they're deficient in a lot of the micronutrients, for example. So if you don't correct the micronutrients, very hard to have long-term correction of that obese state as well. So yes, in general, I find that putting people on a low carb diet is helpful. Very hard to get people to ketogenic, right? Every keto, I get a lot of keto books. People, keto diet books, recipes, patients always bring them in and look, I found this, you turn the page, you see quinoa, done, throw it away, right? I'm like, that's just not going to work. That's the other thing we do. We try everything out on ourselves. So if I can't do it, or if I can't figure out a way to do it, or it doesn't work for me, I don't impose it on someone else. Right. So, and the entire team, I don't ask my team to do it, but we kind of have a similar mindset. So we're always running these protocols on ourselves. And then it's fun because we can jump in the decks, we can, measure, kinds of things. So it's fun that way. But I always, before I bring something to a patient, I want to make sure I can do it. I can do it reasonably, and it's not going to be a fifth job, and you want to make sure it's affordable, that kind of stuff. So all the basics. So I do like to keep them low carb. It's very hard, as I said, to keep them ketogenic. And in general, I don't see the need to long term unless they have some, very strong medical indications. So if they have intractable seizures, that's one, right? So you can do that. However, with that, if you give them low carb, it does help with satiety. I will tell you that I always tell my patients, right, there's physiological hunger and emotional hunger. Many people will complain of hunger, but it really isn't a physiologic hunger. And if you can't distinguish that, then you'll be running in circles because your patient's constantly telling you that he or she's hungry, and you keep trying to arrange the macros and change things out, and you realize no, we're not talking about the same thing. Also, having done this for so many years, many patients are afraid of the sensations in their body that maybe are indicating that, okay, I maybe will in the next hour or so need some nutrition. So any just slight, indication that, oh my God, my stomach gurgled, and they panic. They really do, because they don't know what it means. And so they will eat something. You all often will hear people go, I have hypoglycemia. Yeah, eat more sugar and you will make sure you have lots of those episodes, right? So, but they're thinking I have hypoglycemia, and so they get terrified, and maybe they felt a little tired, and now they're gonna obsessively drink the orange juice because they don't want to get that state. So you have to manage those things as well.
How effective do you find in your practice for lifestyle modifications for treating things like hypertension or dyslipidemia?
So that's my bread and butter. People come, patients will say, but I've had hypertension for a long time and diabetes. I'm like, that's a pretty boring case, because that's all our patients, and yeah, it's very effective. We do get the blood pressures down quite well. But I've noticed that if you especially if you've had some of these chronic diseases for a longer time, then it's really, really important to get the visceral fat down to a certain level. So I set them a visceral fat target, which we measure on a DEX. But because I know if you can't get it below that level, it's very hard to control the disease, right? So, I always make sure that the patient is aware what we're going for. But yeah, we have very good luck in, or our history in taking people off medications is pretty good. It's more the case that we take people off or reduce doses than increase. I don't think I ever really increase doses.
Yeah.
If the patient is following. Yeah.
That's amazing. And just to be clear, these are patients with type 2 diabetes on insulin and fairly substantial drugs. You can be effective with those patients also.
Yeah, and I've treated type 1s, right? And they've done really well as well. In fact, prior to the discovery of insulin, the one thing that did prolong the life of type 1 diabetics was to go on a ketogenic diet. It makes sense, right? They still died, but it prolonged the lifespan. So, and then we're always terrified of, oh my God, we can't cut the carbs in diabetics, and that's crazy. I had my type 1s coming in telling me, they want me to eat this and then shoot up my insulin. What is this? Doesn't make sense.
Do you use continuous glucose monitors in your practice, or ketone breath monitors or anything like that?
The type 1s we do, the others, I've done this for a long time. And honestly, my patients will tell you this. She can just look at you and she'll know. Like you, I need to talk to you. So you just get a sense of, after treating so many patients, you get a pretty good sense. I don't rely on those things. And, I've had patients where they didn't lose a lot of weight. I just had one, in fact, and this was a lot of fun because she didn't lose weight. And she came to me and she said, what do I do? I said, we're going to add more. I added a meal. And she looked at me like, I said, that's what we're going to do. But, I have to give it to her. I've worked with her for a while. So she trusted us, and she did everything, followed everything carefully. So over a 3-month period, she lost 5 pounds, but she really got her VAT, which was well above where it should be, to goal. Right. She lost basically all of what she lost in that 5 pounds was all visceral fat. She increased her muscle mass. Her percent body fat came down. So what do you care? It's 5 pounds, right? It's the right body composition. So that's what I keep emphasizing. And that was, I'll probably make a presentation out of that, because she just kept looking at us. Are you sure? Are you sure you added that meal? Is this, going to hurt my weight loss? I said, I'm not going for weight loss. Right.
Yeah. That's very powerful. Now, can patients join your practice? Do they have to be in the Boston area, or do you provide any sort of telemedicine services that patients from around the US or around the world can access your services?
So currently it's in the Boston area, although we are actively working on this ability to deliver our services virtually. So I would ask people to contact us, because we're very close to having that happen.
Oh, great. That's very exciting. Well, now let's turn the conversation to you a little bit, if it's all right. Knowing, as an expert in obesity and metabolic disease and lifestyle changes that you deal with every day with your patients, how has this knowledge informed the personal choices that you make in your life? In other words, what does your lifestyle look like, Vyvyane, if you don't mind sharing it with us?
No, I'm happy to. I always say, never ask someone to do something you're not willing to do yourself. So my patients know this. If I ask them to do something, I'm doing it, or I'm working on it. Okay. So same thing with the rest of my team. We may not be perfect, but we're definitely working on it. So I prioritize my sleep. It's not negotiable. Anybody who wants an early morning, so you know what, Rob, you're special, because I usually don't do anything.
Thank you. I appreciate it.
I was like looking at it, and then I was like, I don't know, right on, but I normally, it's just a straight no. That's not going to work for me, right? So I really protect my sleep time, and then timing of meals. We go by the clock. So I log my meals, but I also keep my intervals pretty stable, because you do set your circadian rhythms by your meal timing as well, right? So the secondary clock setters, the primary being the SCN. So I use
any
the
fasting in there with the meals, any gaps or intermittent feeding?
I used to do that, but here's a couple of things, right? First and foremost, I think the main benefit is that we get people to get to a slightly ketotic stage when they do the intermittent fasting. So, with most of my patients, they are pretty low in carbs anyway. I'm not sure if there's a huge benefit to that. But the bigger thing is this. My patient population, I have some younger ones, but I do have primarily people from their 40s and above, right? So we're talking about the stage where they have anabolic resistance. Now I need to get a certain amount of protein in per day, and I need to dose it per meal. Okay. So if you're going to do that, you have already some constraints if you're going to have a long non-feeding window, right? Because you're not going to be able, and some people will try to like lump in all the, it doesn't work that way. So, pacing them out. So I will, in general, try to keep a 12-hour fasting window, overnight. But if I can't on a patient, because I'm prioritizing the protein, then so be it. So I do that for myself. I watch that. I don't really keep a long window, probably like 12 hours now. Mandatory, every day I start the day 1 hour of meditation, and then I do an hour and a half. So it's an hour of exercise, mostly resistance training. And I experiment with different things. So we just did a protocol with blood flow restriction, but we'll try different things. But I do that. And then I have half hour for mobility and flexibility work.
For your 1 hour of meditation, is that, I guess you're probably not using any apps for that length of time. And what school of meditation do you use, or what philosophy? Is it like Vipassana or TM or?
Vipassana, and I also fairly frequently do mantra meditation. So between the two generally, but I feel that the meditation also extends into the workout period because, as a dancer, right, you go into a dance class and you're working on technique and you have to feel every part of your body, you have to feel that integration. So when you're working out, it's that being present in the body. I'm very interested in this phrase that I just recently heard, that the body is the mind, right? And this is by someone called Elliot Hulse. And it's just a wonderful way to capture the fact that, your everything that's in your mind is actually reflected outwards in the body. As a dancer, that resonates with me.
That's beautiful.
So, yeah. So in the exercise period, I consider it an extension of the meditation because it's really embodied, an embodied practice for me.
Wow. So an hour of sitting meditation and then segueing into an exercise space. Wow. That's
hour and
fascinating.
A half if I add in the flexibility and the, tendon work and things like that. So.
Wow. That's great. Well, whatever you're doing, it's obviously working.
I think so.
Well, Vyvyane, how can our listeners follow you on social media? Or we're going to list your website on the show notes, but maybe you could just tell us tell them how to get to the website also for people who are just listening to this.
Sure. It's transform-afh.com. In terms of social media, so now this is the next trick, right? 1 hour meditation, 1 hour exercise, half hour stretching. Where do we put the social media in there? That's a little lacking right now. Working on it. Yeah, we are working on it. Probably we'll get some help with that. But mostly our website. I do have a very small YouTube channel. I actually have a lot more videos, but we don't post. So, again, meditate, post. We're going to
Well, thank you so much for taking the time to spend an hour with us today. It's great to get to know you better as well. And I want to stay in touch, and hopefully we'll speak again soon.
Yeah, maybe we'll have a joint meditation session next time.
I love it. I love it.
You won't need the sound, everybody.
I'm gonna put that on the calendar.
Okay.
Thanks again, Vyvyane. We'll see you soon. Bye-bye.
A lot of fun. Take care. Bye.
This is for general information and educational purposes only, and it's not intended to constitute or substitute for medical advice or counseling. The practice of medicine or the provision of healthcare, diagnosis, or treatment, or the creation of a physician, patient, or clinical relationship. The use of this information is at their own user's risk. If you find this to be on the value, please hit that like button to subscribe to support the work that we do on this channel. And we take your suggestions and advice very seriously, so please let us know what you'd like to see on this channel. Thanks for watching, and we hope to see you next time.